Adult Polycystic Kidney Disease. I'm sure some of our audience will not know exactly what is it. I want to ask you, Dr. Dujanah, what is the adult polycystic kidney disease? And what's the prevalence globally, but also in Saudi Arabia?
Thank you, Dr. Fatma. Hello, everyone. We are actually the very last session.
Absolutely.
Yeah. Okay. The ADPKD, or the adult polycystic kidney disease, or the A sometimes go for autosomal dominant polycystic kidney disease, stands for the very common renal involvement in the hereditary form. And it's characterized, as we are going to hear from our esteemed colleagues here later, it's characterized by a progressive cystic formation of the kidneys and filling of that cyst. So again, we'll talk about the kidney volume. And that's progressive, and it may end up in end-stage renal disease. Now, how common or how big is the problem? Now, it depends on the studied population. There is a discrepancy between the population-based studies and the genetic-based studies. But let's talk about 1 in every 1,000 might be an adult polycystic kidney disease, okay? Again, depending on the population studied. And if you look at the end-stage renal failure patients who are on dialysis, how representative the disease out of these patients, again, it depends on the population studies. In the Western, like the States, it's about 2%, 2.5% of the dialysis population have ADPKD. But if you look at more of our regional area, like in Diaverum again is not only MENA area, it's global. So when we looked at the data of Diaverum, which is about 41,000 dialysis patients, it's about 1 out of 20 patients is an adult polycystic or being labeled as a cystic disease patient. So it is common, but not very common. But the problem is that it's hereditary, so it can run in family, and it has extrarenal manifestation. So it's not only the kidney, it's the liver, the brain, and other organs also.
Thank you so much, Dr. Dujanah. And thank you for reminding us also about Diaverum, who is the third provider of the dialysis worldwide. And I think also that you are now in UAE. You started being, in fact, operation UAE. Congratulations and big applause to our colleagues, please.
Thank you.
Congratulations. That's a fantastic news for UAE and the region. Thank you. Let's go now to Dr. Omer. And Dr. Omer from ACLDC, could you give me an idea about how common is the same condition in UAE?
Yeah, so that's a very good question. Because the disease is not very well known in the United Arab Emirates, we still don't have a true reflection of the prevalence in the UAE, but it's likely to mirror that of the Kingdom of Saudi Arabia, which is 1 in 500 to 1 in 1,000. One of the difficulties about this disease is the lack of awareness, and we're trying to increase the awareness of this disease, not just among patients, but also among clinicians, because of the difficulty in the diagnosis. It requires multiple scans, tests, genetic testing, but also the significant lack of awareness of the patients themselves to come forward to get tested if they have any family history. And so this is something that is a work in progress, and we're likely to get more information on that in the next couple of years. We're leading in this field in the United Arab Emirates, indeed.
Thank you, Dr. Omer. Then let's go to Dr. Azza. Let's see, in fact, from an innovation, from a genomics, if there is any good news, if there is any tests. Where are we from Emirati Genomics program as well? Please, good news, Dr. Azza.
Sure, all good news. In fact, yeah, the Emirati Genome Program, as you mentioned, it make a big change, drastic change, in fact, in a good way, for the medical care. Because before this kind of genetic diagnosis, we were not able to understand or to tell the patient what to do to manage properly this patient, and also to screen the rest of family member. Now we have tests which are available, and we are closely working with ICDLC, with Dr. Mustafa and Dr. Omer, to diagnose those patients where we find mutation in a good number of these patients. We just started, but in just the first few cases, we find the mutation in these patients. So we can do whole genome sequencing analysis for these patients, panel analysis for the kidney, specific panel analysis. We have also the pharmacogenomic test, which will help us to choose the proper treatment, because these patients are liable for kidney failure and chronic kidney disease. So we need to choose the proper test, the proper medication for these patients. Otherwise, they will start earlier the renal failure. So we have I think most of the tools are available in-house without a need to send the sample abroad. We have the test result within 28 days from doing it, so it will be helping the physician at the back end to choose the proper treatment, not only for the patient, but also for their offspring, because this is a dominant condition. So this means that each patient has a 50% risk of transmitting this kind of inherited disease to their offspring. So we can prevent it from happening, and we can diagnose. I was talking with Dr. Mustafa about the guidelines. If a person, a mother or a father, are carrier of a mutation, so when shall we start screening their children under the age of 18 years? So I think it's very important to put guidelines for this kind of screening to manage them properly. So a bunch of tests are available in M42. Thanks God for those patients, and we have all the technology available in-house to do the test, to diagnose the patient, and to have a center of excellence for kidney disease in UAE and in Abu Dhabi, of course.
That's a really good news, Dr. Azza. Thank you so much.
Thank you.
Then let me ask Dr. Mustafa how this new innovation and this new test, in fact, are impacting your practice, your clinical practice for this condition.
Well, thank you very much. And I'd like to say that M42 is one of the leaders in technology, healthcare technology in the region. Here today, we have the expertise from the United Kingdom or the Saudi Arabia, Diavaram, which is a much more global perspective, senior consultant nephrologist, a senior professor of genomics. We have the treatments available to become a center of excellence for this disease.
And we have an eminent consultant nephrologist as well.
Now,
Exactly.
to put it into perspective, it is autosomal dominant, but this is a disease that grows slowly in the body, undetected. The kidney enlarges and it compresses the normal renal tissue. There are two of the genes that are responsible, the PKD1 and the PKD2. And these genes implicate cyclic GMP within the kidneys to accumulate fluid. And we know that there are molecules that are implicated in this process that we can now treat to delay the progression of the disease. And how does the M42, the genomics, the clinical facilities, the epidemiology interface with this? Well, let me give you an example. I have a family. One of the mothers has kidney failure in her late 50s. She has 5 children. One of them has the disease, but is developing the disease with kidney failure in her 30s. She has 4 girls. and they are all around 18 years of age. We can now detect this disease in their genes. We can look at the expression of its severity in the local population. We can then move forward to prevent this disease by pre-pregnancy genetic counseling. And that is just the tip of the iceberg. We can diagnose the disease more accurately, and we could do none of this without Professor Azza.
Genetic testing available in M42, I think, facilitate a lot of these connections, because it's very difficult when the test is not centralized. So Dr. Mustafa sent us the mother, we analyzed the mother, she has a deletion, and then he sent us the daughter, she has a bigger deletion in the same area. So this might be due to crossing over of the genes and the chromosomes during crossing over process in meiosis, and that's why this might explain why the daughter have a more severe symptoms. So I think like this we will reach a diagnosis. We can identify new genes even involved in the process by seeing what are the genes involved in this disease, and identify, make a phenotype, genotype, and classification, stratification of the patient. I think this is a big impact for the healthcare, not only in UAE, but worldwide as well.
That's really fantastic. And I know, Dr. Mustafa, that you know very well M42, and you are familiar with a lot of innovation. Do you think that AI was part also of the solutions?
Well, thank you. And again, a very, very important question. And I discuss with my colleague, Dr. Omar, on a daily basis, where we are seeing patients that have been discovered to have cysts in their kidneys. But we don't know whether that is cystic kidney disease, how that will develop, whether it would be important to follow and treat. Dr. Omar, what are your thoughts on that?
Yeah, so I think artificial intelligence is playing a big role in medicine in general. And one of the difficulties about polycystic kidney disease is its ability, as Dr. Mustafa said, it grows very slowly. So if we can predict who's actually go on to develop these cysts at a younger age in the future, who will develop these cysts, then we can predict who is likely to need treatment at an earlier stage, and therefore reducing the risk of developing kidney disease in the future, or slowing the progression of the disease itself. And so there's a huge implications. And I think having that information alongside the genetics will be able to predict those who have high prognostic indicators for faster progression compared to those who have a slower progression risk. And also, I think the literature at the moment, most of the genetics come from the Western world, so Caucasian genetics that we're relying on. But actually, we don't know the true genetic makeup behind the polycystic kidney disease in the region. And I think M42 will be a leader in this world for sure.
This is fantastic.
I need to second this, really. It's a very important point. Dr. Omar's point is that we don't know what is the genetic prevalence of the chromosome, which chromosome, as Dr. Azza said, the mother has a different than the daughter. Probably the father has an element of interjection here. Because I had a case of one ADPKD1 and the partner was ADPKD2, and the children presented with the disease very early. They're supposed to have it on the 5th decade. They had it on the 2nd and 3rd decade. But I would think more of AI help into the Emirati genome studies. The Emirati, we've been hearing about it for the last 2 days, that they screened somewhere around 750,000 population.
800,000.
800,000.
Yeah.
But if we can tell from this data, not patient case, it's a population, a genetic base. If they can, AI will be able to tell you from this population how many of them will have the disease, the chromosome defect. So you will be attending to the problem from the other side, from the bigger base, you know what I mean? And again, Dr. Azza will be telling you that it's a silent disease, as you said, and even if you have the defected genome, it does not mean that you're going to exhibit the disease. You see? So, but this is one way of looking at the AI application of the mass numbers. Get those patients out, probably follow them up, and that will be a unique land break study. Nobody had it before, you know?
Fantastic, fantastic. I think Diaverum being on stage and in the picture in UAE, we're going to have fantastic research. I know that you have a lot of focus on research. Dr. Azza, how can we have this happen? Tell me. Can you answer the Dr. Dujanah?
Exactly. Just to answer to Dr. Rizwana, we have different form of kidney diseases. We are speaking about the autosomal dominant, but we also have autosomal recessive, and we have a polygenic also kidney disease. So if we can create a polygenic risk score for the polygenic, if you analyze transverse analysis of the whole population, as she mentioned, we can create an IRB with the Department of Health. We already have some program running like this for cardiovascular system. We have also for the oncology program, we have a general population screening program, not only patient-based, but also population-based. Asymptomatic persons who are screened, we can do it at the level of the data anonymously without saying that this is belong to this person, or we can do it for people who are willing to analyze their data. We started already with the oncology program. We have about 200 patients that we are receiving in G4, not patient, it's a participant who would like to be screened if they have a cancer or not. They come without any family history and we screen them. So both options are available, and we have a regulator who is very supportive in UAE, who have a big vision of the clinical use of Emirati genome program, and we are just amazed by what they are doing. We have to support them because they have this vision, and I think it will be a driving project in not only in the UAE but in the Gulf region and in the Middle East.
Is it not a fantastic team? I'm coming for a panel of discussion ending with a research program and a research project. Okay, come and join them, please. Think about a project with them. Any question for them? This is a valuable panel.
Yeah, hello everyone. And I'm a nephrologist. I practice in the United States. And I have told you, I'm extremely impressed with M42 being at the forefront of medicine in the region, able to have preventive programs and high technology to really treat complex diseases, and such a great panel right here. So my question to you, as far as treatment, we talked about prevention and diagnosis and so forth. My practice, we have about more or less 30 patients who are under treatment with a medicine called tolvaptan, which is a pill that is taken, and it's supposed and actually works in actually delaying the progression of kidney disease, either by shrinking the volume of the kidney or progressing the worsening of the kidney disease. I wonder what is the experience in the region here with this medicine?
We had, tolvaptan is a new medicine just been approved by FDA in the European Union, and Japan is being used even for acute progression of adult polycystic kidney disease. I'm not sure about the states. It's been approved and used. Yeah, okay. It's a very expensive medication, and we had a center of excellence in the kingdom in Riyadh, and they have somewhere around 33 patients. Who are supposed to enroll. Out of these, 21 patients on the medication, but it needs to be governed by a clinical protocol, selection of the patients, screening, and the follow-up, and all that. And it's too early to say about results. It needs time, and I'm not sure yet if we can, if it's going to be published soon. I think it would need at least 2 years to do that. But I understand, Dr. Mustafa, you have the drug in your formulary in the M42 and the ICLDC.
Absolutely. So we do have the registered tolvaptan available for our patients, and as Professor Azza said, we are in the process of preparing guidelines.
Yeah, because it needs it.
Yeah, so I think we have great expertise, although we're now talking about polycystic kidney disease, but Imperial College, we have a track record of being world leaders in diabetic kidney disease. And so what we're trying to do here is to establish a firm baseline on which we can build the platform, and the genetics, the diagnosis, and the treatment are all available for us. And we're building this track record alongside the evidence, and we're trying to ensure that we keep the patients with us at the same time, because this medication has a lot of side effects, and you have to carefully select the patient who would benefit from it. This is not just a simple drug that you would give it, especially in the region. The challenges we face are different from the Western world in terms of dehydration. In the summer, this medication, if not taken with appropriate amount of water, could be deadly. There's liver toxicity involved, etc. So it needs a solid protocol to be established. We are in the process of ironing this out. And as I said, because of our previous experience with being world leaders in diabetic kidney disease, this is something that we are very keen to take off the ground very quickly.
I agree, Dr. Omar, but I need to highlight to the audience, it's a new medication, very promising medication, and but we need to make sure that there are other factors in the management which is really important, like managing the hypertension of these patients. This is of prime importance, managing the hypertension, because all patients need to be managed in that way. But for this new medication, which is promising, which is expensive, which is for certain category of patients, it's a small sector. You need to keep the baseline managed.
Dr. Rizwan, what is the future? Dujanah, sorry. Sorry, I apologize. Dr. Dujanah, what is the future?
We are here.
Absolutely. The research is going.
This session by itself, although it represents 5% or 2% of the population of the end-stage renal disease, but still awareness, bring it in focus, because there is something can be done about it. Genetic testing, screening, identifying these patients, start with them with as early as this new medication probably. So this is the future.
So I think we have Diverium, who are very successful in Saudi Arabia, now present in the United Arab Emirates. Imperial College that do not need any introduction in the United Arab Emirates. You have the Emirati genome that need no introduction. So I think it's a no-brainer when you bring all these institutions together, the outcome is likely to be of great significance.
Looks fantastic. Then, Dr. Mustafa, after this session and next week when you go back to ACLDC, what are you going to say to your patients?
In the remaining minute I have, I think we need to really create a foundation, a guideline. There are sensitivities. Our patients don't want to perceive themselves as being ill or weak. We need to involve psychologists, social workers,
pharmacists.
Professor?
Exactly, I agree. I echo what Dr. Mustafa mentioned. It's a transdisciplinary approach, not only multidisciplinary, but it's a collaboration between different disciplines, even paramedical like pharmacists, pharmacogenomics, all these kinds of social workers, psychologists. because of the guilt feeling of discovery of the disease in one of the parents. This means that each of their children have a 50% risk of having the disease, especially that most of these cases are discovered after conception. So we have a way to prevent it from happening for the next generation, but we also have a way to support them on the actual status.
Let's say that there is only positive news. The research is here. The amazing and fantastic team is here. And M42 is here to support you. By that, I would like to thank you and tell you it was fantastic to have you on board in Harapet.
Thank you.
Thank you so much, and thank you for all our audience.